Thank you again, Usman. It's my distinct pleasure and privilege to introduce to you Dr. Wilson Tang, who has been an accomplished researcher in the field of congestive heart failure and cardiac transplant. His present appointment is he is a professor of medicine at Cleveland Clinic, Lerner College of Medicine at Case Western Reserve University, and a director of the Center for Clinical Genetics at the Cleveland Clinic. He also serves as the director of the Clinical Research Unit at the Clinical and Translational Science Collaborative of Cleveland and the research director for section of heart failure, cardiac transplantation medicine at Cleveland Clinic's Heart and Vascular Institute. He has published numerous papers and has been a primary author of several papers, including research papers as well as investigations in field of congestive heart failure. He has been a member and a fellow of several societies, national societies that includes American Heart Association, American College of Cardiology, as well as Heart Failure Society of America's latest clinical guidelines. And he is, as a clinical and clinician scientist and practicing heart failure transplant cardiologist, Dr. Tang's translational research focuses on understanding of the cellular and molecular mechanisms that contribute to disease progression in heart failure, specific to cardiomyopathies as well as cardiac renal syndrome. He has been elected as member of the American Society of Clinical Investigators in 2013, a National Honor Society for Physician Scientists for his contributions in heart failure and cardiovascular research. And he has served as a member of the writing committees of American College of Cardiology as well as American Heart Association for Heart Failure Society of America's latest clinical guidelines in the management of heart failure. I can't find any better person to present to us the latest on emerging therapy on congestive heart failure. And it is my pleasure to introduce Dr. Wilson Tang, and he will be talking on emerging therapy. Please help me welcome Dr. Tang.
Thank you. I guess still good morning, although the morning is getting longer and longer. You probably heard a lot already. In fact, most of you can probably come to the podium and start telling everybody else that heart failure is bad, it's worse than cancer, we need to prevent it, there's many drugs, there's still a lot of problems, and it's costly. I wish I would spend the next 45 minutes actually doing some counterpoints and change all my slides. Because I think it reminds me of actually a pretty famous quote that's usually made by many deans of medical school when people graduate is, we know half of what we know now is actually wrong, we just don't know which half. And in fact, there is a paper in Annals of Internal Medicine about probably 10 years ago now that actually looked at hepatitis treatment. And they actually really looked throughout the decades and did find the half-life of truth in that field at least. It's about 12 years. And of course, now with the hepatitis C treatment and all that, everything kind of goes even more accelerated. I actually started my career right at the time when beta blockers is around, just available, and I think that is one of the reasons why I chose heart failure, because failure is no longer a part of this. There's a lot of people actually dramatically got a lot better, which is almost a surprise. And in fact, with all the accolades, very kind words that Dr. Doshi said, I spent a lot of time before residency trying not to do research. So for the young trainees here, just remember the main reason why we are doing what we are doing is because the patients still need us. We still don't know a lot of things that we do. In fact, we continue to not know what they do. They actually raises more questions than answers. And I think part of the challenge of our current medical education system is that we forgot to ask these questions. In fact, the patients ask these questions to the point that we basically gave them an answer and be very comfortable with it. And I started by saying this partly because I think a lot of things that you heard today, and including the talk that I'm going to give, a lot of it is really, as we said at the very beginning, beliefs, strong beliefs that we think the evidence is there. But I think the key is actually to keep finding the evidence, particularly the tools that we use to demonstrate those evidence. And in fact, one thing that I would start off by saying is the actual definition. It's funny, it's been 3 hours and we actually never even talk about what are we talking about, which is heart failure. So I'm glad I actually kept this slide. Prakash actually stated it word by word. Actually, he did read the guidelines. And the problem here is that, you know, if I actually ask all of you to actually describe it, what is heart failure, it will be very different because everybody has their own view, has their own memory, and their own visualization of what heart failure is. This picture has been actually in the Netter SIBA albums, and the only difference is that now we have a lot more gadgets. You know, this guy is actually new, and this guy is definitely new. But the syndrome and the presentation remains the same, and it actually is one of our problems. We actually do not have a very objective definition. It's almost like treating anemia when we're just measuring the blood count, and we don't understand the biology behind it. Guess what? Our administration, sorry about that, this is the next talk, but I guess, decided that we need to actually define it. And I have a lot of trouble figuring out how to code, not just the ICD-10, okay? ICD-10 is, I think, is actually a great tool. But sometimes, how do you decide it's acute or chronic, diastolic, systolic, or combined? In fact, most systolic has to have a diastolic abnormality component. So it's really rare to have isolated systolic without the diastolic component, unless you rely on the echo. But if you can only stretch, you know, to build the 20% ejection fraction, you have a trouble releasing it. You know, so physiologically, many things actually don't make sense, and we are very comfortable with it. We're okay, you know. If you think about it, we talk about ischemic, non-ischemic heart failure. If we're non-ischemic, we're fine. You know, do we know what? No, not really. Idiopathic dilated cardiomyopathy, we have no idea what it is. So patients would be asking us, why do I have heart failure? We have patients coming to the Cleveland Clinic to say, why do I have heart failure? Why don't you know about it? Actually, that's the main reason why I went to do research, and now I actually have a translational lab to actually try and do that. The bed to bench and back has actually been a very successful story in heart failure. This is one slide that literally summarizes 40 slides of what Prakash did. And you can see one of three things. Number one, it really is not related to the severity of the heart failure in terms of the indication. The mild, moderate, severe, we got to take those drugs. And this is what the clinical trials taught us across the spectrum. There's still some gaps to be filled, okay? But I think it becomes clearer and clearer that we are toning down the system. We're not just trying to classify specific disease severity based on patient-reported symptoms. It's actually it's a biological alteration that we need to tone them down. We need to try to tell the system not to overreact, basically. Okay, it's the overreaction and that's what the post-MI data from Mark Pfeffer has taught us. The overreaction is not just the myocardial infarction that actually damages the heart, but also what happens when the body starts to respond to the changes. This is actually quite important because also, at the end of the day, most of these guideline recommendations also has been tested almost the same way, which is if patients and doctors don't know what the drug is and we started this drug, how many people are alive in X amount of time? what the biggest problems, and actually the most interesting thing about being in 2 guideline committees, other than the fact that we got a lot of complaints about how long they are, is the amount of information, even in the 1A recommendation, we still struggle. Half of the questions that came along just now is about what to do in certain situations. Do you start or stop a drug? Do you actually continue? How do you titrate the medicines? So we still have a lot to learn, and actually everybody that takes care of patients are actually doing research. It's N=1 research. It's your patient. You're actually experimenting the different changes and then learn from it what's the best practice. So with yet another surprise, I'm going to talk about prevention of heart failure. This is actually talked about for the last 3 sections. It is not only an emerging therapy, but it's also a necessary therapy approach. And I'm going to talk about something that actually augments and actually have direct evidence to actually show people. You saw the classification staging. I'm not going to belabor on that. This is the recommendation right now. When you can actually fit everything in one slide, that means we actually still have a lot to learn. For post-heart attack, and if you have a weak heart, we need to give them drugs, okay? If you have bad blood pressure, you need to control that. If you have any reduction without symptoms, and that's subject to definition, I always joke that I could make anybody have symptoms, except for really elite athletes with LV dysfunction. Then you have to put in a treadmill to show that they are abnormal. But there are still some that doesn't, but a lot of people actually do have symptoms that they don't know about. And that's something that's key. ACE inhibitors with the SOFT study, I think you saw, is actually great evidence. Beta blockers actually doesn't have a lot of evidence. The biggest evidence there is actually Capricorn in the NYHA class 1 patient population. Otherwise, most of the beta blocker population has been symptomatic heart failure. And one very important thing that we actually always forget about is the prevention of sudden cardiac death. I think when we actually started having the beta blockers being part of the treatment, patients recover the heart function, we got all happy, and then 6 months later, their family called and they died. And we don't understand that. That's before we have ICDs. And I think that's the main reason is because, as I told people, that like a house, the electrical problem is different from the wall. You know, the electrical problems, there's still something going on that we don't understand. The biology of this problem, we still don't understand. So I'm going to talk a little about natriuretic peptide. That has not been touched on quite a lot. But I think this is something that is an indication of the biology that we actually have recognized and have recognized over the last 16 years now. I have the privilege to actually join the Cleveland Clinic back in 1999 actually, 2000. And that was actually the first year when we actually have the BNP. In fact, I still remember November 1st, that was actually when we got the BNP machine. We actually did the first one. Glad that was normal. But what we were told at that time is the clinical studies done by myself and other folks that, and this has been research done for quite a while, almost 20, 30 years, that this is truly a countermeasure. I tell my patients it's the nitrates that your body makes. And it's not just your heart makes. The majority is from the heart. But the blood vessels, the brain, you know, like any blood vessel, endothelial cell actually makes that. The first discovery is actually in the brain of the porcine brain. That's why it's called brain natriuretic peptide for some people. And there are a family of them, A, B, C, and D, and there are many other combinations now that we make. It breaks down to form an active moiety and a almost like a C-peptide equivalent, like an inactive fragment. And both of them, we could test it. And again, with some new excitement of the drugs, we actually do see that they do have some form of biological function. I'm going to talk about it a little bit later, but I just want to emphasize that it's always a challenge when we started to try and use a new kind of insight into biology and to how to best use it. And a lot of people go down and to try and find it in randomized clinical trials. It's actually very difficult. We're actually in one of them right now, and I actually funded the guided study, which is like 1,500 patients. Half of them, we know the data, and half of them we don't. I'll tell you as an investigator, it's very difficult because half of them, when you really know that they are actually a higher risk and you try very hard with different drugs, even knowing that your goal is to bring it down is actually difficult. So how do we use it now? And this is actually not in our heart failure guidelines, but our friends north of the border actually has devised this already. They actually gave some recommendations, which is really a combination of data, but also a decade-long use of this biomarker by many expertise. I think this is where the guidelines fall short, when all we care about is the randomized control trial data without really helping individual doctors. But in general, the lower the better, and the patient is their own control. I think we heard that early on. I think there has either a rise of an otherwise stable level that is validated in some ways, so it's persistently rise, especially more than 30%. A reasonably large level, a few thousands in N-terminal, I don't know which assay you use here, of more than 400 in BNP. And we wanted to try and intensify heart failure therapy, and I'm going to talk more about some of the options that we have, which is exciting. But most of it in terms of trying to understand what's going on, whether the patient's euvolemic or not, all the things that Dr. Haywood actually talked about early on. And there are many times when we actually do try to bring it down by intensifying therapy. Now, the argument against all this is, why don't we intensify therapy from the first place? I mean, this is all guideline recommendations that you need to maximize the medical therapy. I think there are times when the insight over time on the patient's clinical status do change too, and also sometimes the re-challenge of people who thought they are maximally tolerated really need to be reconsidered, and this is one of the reasons why that would potentially identify those who actually improve. The hospitalization, again, the change is actually less important, ironically, than the actual absolute value. So if somebody comes in with a natriuretic peptide level N-terminal proBNP like in the 5-digit range, obviously they are very sick, and I think in many ways, anybody that comes in the hospital, having this gauge to know what stratum they are, not necessarily how much they fall. The more they fall, obviously had to depend on how high they are to begin with. If you're not very high to begin with, you don't fall that much. One of the more important things is actually talking about this at-risk population, is we do not undermine that without symptoms and without an echocardiogram, which is the majority of patients that we see, that there is a very big potential for us to better identify the subset of patients that would progress. And this perhaps is probably one of the most unanswered question to date, because there are many variable reasons why BNP goes up, particularly if you have less muscle mass. When women is actually smaller than men, and they have lower renal function over time. So if you're getting older and you actually have many other comorbid conditions, you actually get into more trouble. Obese patients, we learn over time now, they actually secrete less BNP. So we have to give them like a 30-40% discount almost. In fact, after bariatric surgery, they actually go up, the BNP does go up. So there is a lot of interaction between the metabolic balance. The natriuretic peptides are actually lipolytic agents. They are hormones that actually lyse fat. So if you actually think about it, at-risk patients are actually the ones that the natriuretic peptide probably has some role in it. And we actually have some data. The last year in Ireland, there's a whole range of practitioners, and this is all in primary practice, family practice across actually the Irish coast. It's a study that looked at basically stage A heart failure patients who are more than 40 years old and have some cardiovascular risk. And they recruited them, and they actually measure the levels, and then half of them continue to measure them and half of them don't. Or actually half of them they show the practitioners and actually ask the practitioners if they're elevated to consider heart failure drugs for their chronic conditions like ACE inhibitors and beta blockers. And then they keep doing echocardiogram over time, particularly after 2 years. And they actually see over time, they actually have more patients with echocardiographic abnormalities if they actually are not guided by the natriuretic peptide levels. And for both, particularly those who have elevated natriuretic peptide levels, by changing the medicines, they actually did see some improvement in long-term outcomes. So this is actually quite dramatic. It's actually not very well publicized because, again, I guess there's no drug companies that actually try and tell us that. But if you think hard about it, this is where the prevention comes. It's almost like the LDL for cardiogenic shock for heart attacks. Okay, we need to go way ahead, 5-10 years ahead before things occur, which is actually many people that you see in the clinic right now without a label, a diagnosis of heart failure. So, and another group of people are actually people that have family history of heart failure. Some of them particularly when they're young. And we actually have a lot of understanding now, particularly with improvement in technologies. When we actually talk about cardiomyopathy, it's always a challenging concept because, again, the definition doesn't help us here. The definition that was coined about 10 years ago basically says it's a very complex group of disease associated with the heart, and there's a lot of problems, and some of it could be genetic. And that doesn't solve a lot of problems here, probably because half of the people that we see do have this condition at clinic. And many of them have pretty good comorbid conditions or predisposing conditions like hypertension and diabetes. However, there are some people that actually have specific reasons. Just like anemia, there are specific reasons why somebody's getting a problem. And the more that we understand the biology now, both just like cancer, with more specific insight, both by imaging and by biopsies, we start to realize a lot of people with so-called diastolic heart failure actually had accumulation of amyloid proteins that actually are called transdiethylene amyloid. In fact, 3% of African Americans actually carry a genetic mutation for transdiethylene amyloid. And in the Dallas Heart Study, they actually show they have a higher incidence of developing of congenital heart failure. So we thought all these patients who have hypertensive heart disease, and many of them may have, they may also have a susceptibility of amyloid depositions in the heart. Why is it important? Because I'm going to show you later, we're actually having specific drugs for these 10, 20, 30 years before the onset of disease. And so we are now starting to think about not just the ultimate, being the goalie of a soccer match, trying to block things from actually, falling off the cliff. I mean, we're actually trying to figure out how to actually play better defense. There are many other things that I'm not going to go belabor, but I think there are many also other advanced cardiac imaging. MRI, we are actually doing a little bit more, although I would strongly urge, I say that a lot of imaging remains observational. It's an observational series of patients. And, but clearly identifying individuals, for example, like transdiethylene amyloid, we have pyrophosphate scans that we could identify them. We could see non-compaction. That probably is overdiagnosed now that we have better sensitive imaging. What is more important is actually some of them are susceptible by nature, not by nurture. And I think the testing capability is much better. The Human Genome Project actually took 13 years and 3 billion base pairs and probably $3 billion. Now you can get your whole gene tested probably within a day, which costs probably in the 4-digit range, but probably in the 1,000 range. It's probably going to be lower. In fact, I think it could be very affordable. I'm trying to count how many lattes is equivalent, and people can understand that. The main reason why it's important because a third of our patients actually do have a family history. I think it's one of the most distressing things as a transplant cardiologist when you actually take care of their sons and daughters and their cousins, or know that their cousins actually died because you actually knew, and the heart is in your freezer in your research lab, and then you didn't know that their relatives are at risk. Now, why is it that now that we have the technology, we don't actually go and seek for it? Now, why is it that we don't even have the ability to actually understand how and when to actually follow these patients? This is targeted screening and understanding right now. And the reason is because the tools are still not completely accurate, and also there's a lot of data. It's like the NSA equivalent. What are you going to realize how the information, you're looking for typos in a very, very big encyclopedia, okay? How does it work? So clinicians have not had this understanding and ability to assimilate that data. So we are hoping to have some kind of creativity in the bioinformatics range that we could visualize the data well. And this is actually coming within our practice. The NIH actually expected that by 2020, we will all be actually having it at our bedside. And I think there's a lot of effort trying to work on it. But I think when do you perform? Obviously, when patients have strong family history, or they present in a very unique way. And the three things I think about is actually when they have a concomitant neurologic problem. Okay, many of them actually have both the nerve and the heart being problematic. Those are the two cell types that don't reproduce too well. So they actually hang around and takes all the toxins that we expose the entire lifetime, and so they're actually much more vulnerable. The family history is important. The conduction abnormalities, many of the laminacees, many of the AFib that occurred early. I always joke that by running a cardiomyopathy clinic, I just go to the EP lab and find the young guys there, because these are the ones that 10, 20 years later is going to come to see me. It's actually quite sobering in that. But guiding family management and hopefully gain insight in pathophysiology and changes in paradigm. We have actually accelerated transplant evaluation for some individuals when we actually understand that those are lethal and very pathologic mutations. And guess what? By the time we finish the transplant, they actually go downhill very quickly. And there are many instances that we actually do that. Now, again, instead of playing defense, we can play offense. This slide is actually not in your whole, there's only an extra slide that I put in. But we now have actually new drugs and new compounds that specific targeted gene-positive patients who are asymptomatic. The hypertrophic cardiomyopathy is a model that is really an overusing. It's an overpowering problem. When the mutations occur, make the actin myosin kind of overreach and try to actually overreact and try to pump harder is an overdrive problem. It actually causes a lot of inflammation, a lot of fibrosis, and a lot of ischemia. And interestingly, this is almost like a beta blocker without blocking the rest of the adrenergic system. It's specifically targeted to the interaction between the actin myosin to almost like a damper to damp the amount of inotropic overreaction. And in many ways, they're in phase 1 study now. So these are actually not very far from us. There are 2 studies in phase 3 that looks at this transdiethrin, the 3% population in African American, that either gene silencing or actually blocking the production of the protein itself, which is made by the liver and folded differently and actually travel to the heart and actually deposit in the heart and causing blockages within the heart by depositing the protein. And these are studies, these are truly gene therapy studies. They are very, very promising and can delay progressions, which could take decades. Now, the challenge, of course, is how do we then prescribe the medicine? I mean, do we have to actually give these drugs on a continuous basis, and how can we understand the effects? The good news is many of these can be tapered like on a quarterly or even a longitudinal basis. So the most exciting part, at least the last 3 or 4 years, has been really the clinical available of several new drugs, which actually changes the way we think about heart failure. Most of the time when we think about heart failure, it's really followed by the drugs that were shown to be beneficial, and then we go back to the drawing board and try to understand why do they actually beneficial. The mineralocorticoid receptor antagonist has been described. One of the things I want to point out in this is it is really very high-risk groups, particularly people that we are worried about putting a spironolactone or a perinone that actually benefit. So this is a counterintuitive part. The main reason is that many of them do have high-risk features. And the 2 main high-risk features to bring somebody to the clinical trial is either you got hospitalized or your BNP is high. So I had the pleasure to actually write that section, and there was a lot of controversy because some people believe that the Ephesus study, the earlier post-MI study, have a lot of people that don't have a lot of symptoms. And so should we have symptoms? Do we fix the same inclusion criteria to actually the guidelines? And the answer ended up being yes, because this drug also can hurt a lot of people. This is a drug that I would not start when I go on a trip. This is somebody that you have to watch very carefully, because if you have not seen a hyperkalemia or renal insufficiency, you have not given enough. Okay, and again, homeopathically, you start off, even every other day to start off with, and surprisingly, many people actually tolerate it very well. Many of them even to our surprise when we actually start. The two new drugs that has been around, and obviously a lot of press and a lot of advertisement, I'm sure many people have come to talk to you about. One is actually not a new drug. Ivabradine is a drug that has been approved in Europe for about 10 years, and for heart failure about 5 years. It's a very unique drug because it blocks a channel, particularly at the conduction channel that we used to call it the funny channel, because it actually acts funny electrophysiologically by the amount of sodium current that changes. And in many ways, it slows down the intrinsic pacemaker. So you can see that if this is a control, which is the normal, by actually blocking the ivabradine at the IF channel, which we now call HCN4 channel as well, it slows down the hyperpolarization. And so it actually causes the repolarization part to be later, the depolarization part to be later, and that's why people's heart rate just stops. It's almost like a reverse of a pacemaker. You got to dial down the speed of the heart rate. We start about 5 milligrams twice a day. It's a twice-a-day drug. You can go down to 2.5. You can go up to 7.5. The interesting side effect is there are some of these channels in the eye. So patients actually would have a little bit of a halo effect in about 10% of people at the end of the retina. It's completely reversible, so it may be scary, but you have to warn them that you may actually see something different, and they need to tell you, and you can dose down the dose. There's no long-term side effects. Now, this is actually combining the two studies that you see. One is actually the original angina study called Beautiful. You can see that there's actually not much of an effect for patients with low heart function. But for those who are sicker, which is a SHIFT trial, low EF, patients' actually heart rate is still high, which is a very bad marker, and they're already on beta blocker. Their heart rate is still 70 and low EF. We actually give the drug, and actually showed a good 20% improvement, actually in this case, quite significant on a large patients. And actually, there is a lot of information in Europe to suggest that it's a very safe drug. It doesn't drop people's blood pressure like beta blocker. And for those who have a challenge of the fast heart rate, kind of almost an inappropriate sinus tachycardia, or that you actually optimize the filling and improve the stroke volume that way. The next class of drug came to us not as a surprise. In fact, there has been a lot of work done over the last 2 or 3 decades by different research laboratories, understanding that there are many peptides in the body that are counter-regulatory. There are many defense mechanisms that the body makes. And some of them are good, and some of them could be an overreaction. But the good ones, but there's a whole very elaborate mechanism to which neprilysin is one of the degrading enzymes. So we talked about BMP, natriuretic peptide, is a good hormone in most cases. And what happened is it has a half-life of about 20 minutes. And this neprilysin inhibitor actually, degrades it into inactive fragments. And there are other enzymes that do that. DTP4 actually does that as well. What it seemed to be is that there are many other enzyme hormones that is also degraded. And previously, we have studied this in 2 different clinical studies that actually failed because of off-target effects. And one thing that people have realized that is the previous combination is with a blockage of the ACE inhibitor. And what happens if you block both ACE inhibitor and neprilysin, you actually have an excess amount of angiotensin and other hormones that ended up bombarding the angiotensin receptor. And in fact, that may be a problem. And in fact, even in this case, what we have to do is for patients who have ACE inhibitor, we do have to stop it for some time, then restart this medicine, because you don't want to have the overreaction part. So the Paradigm study is really a game-changing study for several reasons. Number one, it actually decided to enroll 8,000 patients rather than doing several small studies. They go for literally the Hail Mary. And the second thing is because of that, they actually enrolled a large group of patients. Many of them are actually quite well. So all you have is basically a low EF, And you either have slight hospitalization or slight elevation in BNP, so to demonstrate that you have heart failure. And the key is that they have to tolerate more than 10 milligrams of enalapril. And so these are the people who are already relatively well and stable. So you talk about prevention. These are the people that were waiting for something bad to happen a few years. Interestingly, they give them a run-in period, and 12% of people actually don't tolerate a drug. It actually drops people's blood pressure because more BNP is around, it actually causes vasodilation. But it actually, after a good amount of time, they actually have to stop early because they saw a 20% reduction in CV death and heart failure hospitalization, 20% in CV death on its own, also all-cause mortality improvement, and a 21% reduction in heart failure hospitalization. And this is on well people. These are the residual risk patients that we're talking about. So it's a very impressive set of data that we got. So how do we use it? I actually kind of tell my fellows that this is how you use it. If you think about metoprolol tartrate, in some ways the same numbers, but without the 25, start with 50, which is a combination of 24 and 26. And what you do is for those patients who are low, meaning even lower than 10 milligrams of lisinopril, you actually give less than 10. This is all in the package insert. The trial itself actually started at 100. Okay, the trial itself started at 100, and what they do is they have to hold the ACE inhibitor, in many cases lisinopril or enalapril. In the trials is enalapril for more than 36 hours to actually have the washout of the ACE inhibition. And then every 2 and 4 weeks, you actually go up, and the max dose is 200. So with that regimen, after 2 weeks of run-in, which is open label, 12% people actually drop, most of them because of blood pressure reduction. So hopefully the lower dose rise would be actually more helpful. There's actually less hyperkalemia and slightly more dizziness, but not significant, and no change in renal function. In fact, there may be some hint that they may be improving. So these are very exciting drugs that we have. Practically, it's been well tolerated. The ivabradine is really geared towards really sicker people, high heart rate. The sacubitril and vasopressin combination seems to be even more dramatic in terms of the benefit of earlier heart failure. And in fact, the NYHA class 3 and 4 in the forest plot actually crosses the line of unity. So there's a lot of controversy about the people that we are so sick. Should we actually use these drugs? So the rest, unfortunately, is not a lot. I'm going to actually fly by some of them. The main problem is because we still have a lot of challenges in characterizing these people. We spent a lot of time talking about HFpEF. This is a repeat of the slide that we saw. We really don't have a handle of what is heart failure preserved ejection fraction. In fact, I think we rely too much on the echo for that matter. There is a lot of vascular problem that we understand. The echo findings could literally be a systemic vascular problem, and there's more and more understanding on that. The spironolactone data is helpful. I just want to emphasize there are more hyperkalemia, although the new potassium binder will be fine. We saw this already. I'm not going to belabor that we are different from our Russian colleagues. And ultimately, the thing that the last 10 years that really showed us that biology is important is the left bundle branch block for the cardiac resynchronization therapy. This started off with a physiologic observation, and we usually let the bundle branch block go until they get complete heart block or symptomatic heart failure with conduction abnormalities. And then we realized that it is the inefficiency of the heart that's causing this, particularly with left bundle branch block. The original study is physiologic improvement in hemodynamics using a left ventricular pacer. So they actually cross the septum, go to the left ventricle and pace it, and it seemed to work great and improve the hemodynamics. And of course, the electrophysiology actually figured out a way to go behind to the vein to actually find a spot at the left ventricle. The guideline committee actually have a lot of challenges in doing that because this is the first time that we use subgroup data to actually differentiate our guideline recommendation. And it's very uncomfortable because the last 30 years we've been telling people not to look at subgroup analysis. And we actually ended up doing that, and for good reason, because the refinement of our understanding of the physiology and the biology and the consistent outcomes of the different studies really show us that we need to actually relook at it. And in one way, if you actually look at patients with a left bundle branch block, which is, the signal going through one side is actually slower than the other, versus reverse the right bundle branch block, the effects of the hemodynamic efficiency is actually different. If you don't believe me, actually look at the echoes yourself. Sometimes actually you see the heart actually beats a lot funnier if you have a left bundle branch block. The interesting thing is 150 is the magic mark and 35% EF is the magic number. The joke, I don't know about here, but it's like, if you're 34 or 36, you really get angry with the echo person and go down and negotiate. MRI sometimes help, but the whole point is the clinical suspicion that this is a dysfunctional heart is a very important one. And we even have many times when we have very bad left bundle branch block that we underestimate the severity of the heart, and I think sometimes even, so getting it too late is one of the problems. Forgot about that you need to look at the left bundle or QRS duration because somebody has a device is another omission that people do. The biggest omission, however, is what to do afterwards. Most people don't think too much about it. I mean, you write a referral and get to our EP colleagues and check, done, move on. Fill out get with the guidelines, yeah, I'm good. It's funny because the EP folks actually were very troubled with the 70% response rate. I always think about most beta blockers, ACE inhibitors probably doesn't have a 30% non-response rate. We just don't know. But in this case, some of the non-response is because of technique, some of the response is because of programming, and some of the non-response is because we are under-treating the drugs. In fact, one of the things that I would emphasize, and there are more and more data supported, is that you almost, on average, get a 3 to 5 millimeter mercury increase in your blood pressure when you actually pump the heart efficiently. So this is the chance, not 3 months later, when you actually discharge the patient, you actually try to maximize the beta blocker. And those people who actually got more drugs afterwards actually did better. And so you actually have the chance, almost like a bridge, to actually allow more medicines to be tolerated. Another thing is the optimization of the diastolic filling. This is the only chance that you actually can titrate, almost like your timing belt in your car, to figure out what is the most efficient way. The problem is the last 5 or 10 years, we relied on ultrasound to do that. And the way to do the ultrasound measurements are also highly variable. Depends on the angle, depends on who reads it, and all that. So the layman's way to look at it is get an X-ray to make sure that the leads are far apart. Many times they go to the wrong place or slip, and you don't know about it. Get an EKG. Everybody should be able to actually at least see the EKG. If you get a resynchronization therapy and the pacemaker looks completely funny or the QRS is still very wide, you need to get some help here. So there are some things that we can be the people that are out there trying to identify problems early on, because patients thought that they are ready with a device and doctors thought that they are ready with a device. It's really our understanding and learning of how to tackle these problems. Non-interventional, there is 2 points I'll make. One has already been made, which is the target doses. Okay, what you saw in the pictures before was the maximum doses. So this is actually what you can do maximally. This is actually what the clinical trials ask you to do. And everybody need to actually relook. In fact, almost universally at every clinic visit, I actually have this list in my head, thinking, okay, which drug is it actually there? Why am I not there? This is almost like the checklist approach. The key, though, is actually not the drug, it's actually how patients actually see their therapy as one of their treatment. This is a study that I'm sure the CHARM investigators don't really like to publicize. When patients are taking placebo, more than 80% of the time, they have a better outcome than patients who take candesartan, less than 80% of the time. And you can see the curves, they are actually completely separated, which means that we need to understand and recognize why patients are doing what they're doing, not just that they actually got the drug. Are they taking the drug? If they're not taking the drug, well, if they say they're taking a drug, trust but verify, like ask their spouse, ask their kids to check on them, because this is actually very important. If you think about it, all the interventions that we have I always joke that we should actually have placebo pills in our formulary. That actually helps. But no, that's actually not the reason. It's really the management, the attitude of care that is actually important. We have very little data on others. They are all Bs and Cs. There's 1A, which is exercise training and rehab. Those are actually great data from Heart Failure Action on clinical trials, but only for those that actually use it. So in the Heart Failure Action, it was neutral, but for the people who use the treadmill, they're actually beneficial. Obviously, sodium restriction is what we've been taught. We just been working a lot on many of the electrolyte homeostasis work now, and there's a huge controversy about sodium restriction as a standalone. So in general, high salt is not good. Low salt, if it's too low, it's not good. There's times and scenarios where too low actually could be interfering with treatment. The question is how to gauge it. So we have very bad ways to do that right now. And so again, better tools to gauge it. There's a question about sleep apnea. Interestingly, there is not very strong data to suggest that sleep apnea itself is a contribution of heart failure. There's a huge amount of data on arrhythmia. There's a huge amount of data on treating sleep apnea being a benefit to reduce the recurrence of AFib. And of course, it tracks with heart failure. And for central sleep apnea, with the new ASV studies with SERVE heart failure, they actually did not show improvement in outcome despite using one of the best CPAP machines or ASV machines. So we are still working very hard to try and understand that. There was a question of acute heart failure. This is perhaps one of the more disappointing areas. We still use 90+% of diuretics as the primary target. There has been a lot of benefit and data. You saw it in the first talk that there are some differentiation. But again, the tools are always challenging. This is a classic Lynn Stevenson study showing that there are some people we need to whip the horse, and there are some people we need to dilate the vessels. The studies have been neutral in general. You saw some of the data early on today. There has been some interesting data using a hormone that pregnant women use. Pregnancy is basically the human model of what works to compensate the heart. Otherwise, everybody with pregnancy with high cardiac output and volume overload would actually get into heart failure. And there are some that does. And in fact, my wife specialized in this area, so I became her biobank for that. And interestingly, many things track. BNP tracks. You know, many of the manifestations, they have a readmission rate could be up to like 10, 20%, because after the pregnancy, the vascular problem remains, and there's a lot of fluid adjustments. So the hormone, which is called relaxin, is in a study called RELAX-AHF. The early study didn't show a significant benefit, but did show reduction in mortality. So there's mixed signal in 1,000 patients. So they're trying to understand how to actually use it. So the second study is actually coming out very soon, and we're actually looking forward to the results. This actually is an alternative. If we actually try and figure out not kind of one size fit all, but how to identify these people, the key is to find better tools. And this device actually early on was developed and devised at the Cleveland Clinic. And at the time when I was a fellow, I actually got a chance to actually participate in the development of this. And we've never left anything in the pulmonary artery before, so that's always a very nerve-wracking experience. But this device has proved to be very, very effective and able to actually determine signals, at least still directly, manually, and allow direct pressures to be calculated. And we actually know very well for the last 30 or 40 years the amount of pressure that we need to follow. And indeed, for very sick patients, 550 patients with reasonable kidney function, there is a dramatic improvement actually in hospital readmissions, even all-cause mortality in the long-standing follow-up data, and a combination result. So, and it works both in heart failure systolic dysfunction and preserved ejection fraction. So the actual hemodynamic compromise, that's what we always see in the end of stage or later stage. If we actually have basically the headlights to know how to drive a winding road is actually somewhat helpful, because half of what we do is harmful, as you remember. The dilemma for stage D is always whether we are inadequately treating them or that the end is inevitable. And this is something that you need to know the patient, and you know the patient well. And you also need to possibly many times have different eyes looking at the same patient to actually generate ideas. This is actually where at the Cleveland Clinic we actually have a lot of fun trying to understand with each other's expertise to understand the best for our patients. And many of them actually requires a lot of objective evidence. Basically three things: end organ problems and symptoms and functional capacity that neither the patient or the doctor can describe, meaning objective data, because they would tell you that they are feeling well, and then you put them on a treadmill and they can't move. And these are things that happen all the time. And the hardest thing for a transplant referral center is when patients are really too sick. I like to see them at least a year before or 2 years before, where we understand the patient, know that they can tolerate. This is like dating. You don't want to actually get married, the next day. This is a commitment, for better or for worse. I actually use that analogy a lot. It's a commitment for us, particularly with transplant. It's a very important thing. There are novel biomarkers. These biomarkers look at different mechanisms. They are all FDA cleared. The problem of them is that most of them actually have not tracked with medicines. In fact, the lower the levels, the more beneficial maybe they are with drugs. So it seems like these are what we call death markers, and continue to have challenges with actually using them. But I think ongoing studies are hopefully going to clarify it. The replacement therapy, the last 4 slides, I'm going to talk about how heart transplant is still our primary goal for those who are eligible. Every relative indication has been refuted in some centers at some period of time. So there's actually a very challenging scenario, particularly when patients are getting older and also retransplants are occurring. There's many ethical issues. We just transplanted somebody who was 73 the other day, and guess what? I just saw the patient that when I was a fellow got transplanted 12 years out, and she's actually quite old now. So there are many people that does surprise us. It's not the numerical age, but the actual health of the body in many ways. So we judge everybody at one time. The survival is remarkably good at our center right now. The 3 years is about 80%, and 5 years about 75%. And this is actually quite a remarkable feat, considering a few decades ago we struggled with it. We don't do a lot of combined transplant. Much of it is because the drugs are actually a lot better, and we actually find ways to refine it. Complications does occur, again, for better, for worse. There are many things: hypertension, renal insufficiency. Many of them actually behave differently, but the long-term outcomes of vasculopathy, malignancy, and graft failure remain the biggest challenges for us. That's where the pumps come into play. The pumps have been around since 2007, and it's really revolutionized. Right now, most big programs actually have half of our patients doing transplants and half of our patients doing ventricular assist device. In fact, the majority of patients either on a drip with an inotrope or having a pump, and only about 5 to 10% walk in without either. So it's a very, very different landscape right now. They also get smaller, from the very big ones that actually pulsated, also go in the outside, to smaller ones. These are the ones that we have now. These are the two, the HeartMate hardware and the HeartMate 2. HeartMate 3 is actually in the middle of the enrollment right now. There are smaller ones that actually implant with smaller cardiac output. There are also percutaneous ones that we put in all creative places to try and do it transiently. It is a pump. It is, as I call it, a fish tank pump. It's a caterpillar pump. And so anything that relates to the caterpillar pump does occur, including clotting, including infection, because there's a line coming out. If you think about it, you're putting the bloodstream in the blender in many ways, so things do break. There are problems with how to set it. We learn a lot about human physiology. You can see that the pulsation in a low speed could actually be completely demolished if you drive at very high speed. So we are still learning a lot, because when you don't have a pulse pressure, you do have a lot more GI bleeding. We learned it from the aortic stenosis literature. And there's a lot of non-medical problems that we deal with: nutrition, depression, comorbid conditions, psychosocial problems that related to a long-term indwelling or externally connected device, and not a lot of long-term output. So But the problem is a lot of our transplant patients also have a lot of comorbid and complications that we deal with. The survival got dramatically better over the last decade and a half. Now we actually could boast almost equivalent in some of our patients with transplants, and that's why the benefit continue, although there are also many challenges. So I run a very, very quick list of all these emerging therapies. We have many choices right now. The key is for practitioners across all specialties and patients to clarify what is best for them. And that you cannot actually get in clinical trials. That's get from you and your patients. And I think the key for us is that we are very humbled with this condition. We still lose a lot of patients. I think the key is to work together to try and understand and to question all the things that we are being told. Because in 10 years' time, half of it will be different. And this is the reason why we're doing this. This is actually the exciting part because there's a lot to do. Thank you very much.
You talked about the Arni-Valsartan combination, and obviously Novartis is about to descend upon doctors' offices to try and get them to switch all these people to...
You mean they're about to?
Are trying to get them to move off of these things. Estimated at about $4,900, I guess, is the estimated price. Can you tell us when you would use the more expensive treatment?
Yeah, it is. This is one of the biggest dilemma that the field has been encountering, and there are obviously different points of view. And the biggest challenge is actually bigger than ivabradine, because ivabradine, at least you know the sick people that you really don't have a lot of options and you try that. This is where this is truly a preventive option. So we have been, just like most new drugs, we have been trying it slow. We've been trying it mainly on the people that we felt, particularly they have a life expectancy that is long and also have enough blood pressure, so we don't do a lot of marginal ones. Our uptake has not been very high. Just like the beginning of any new drug, we've been very, very squeamish about doing that. And again, only until recently, the CMS is working on the reimbursement, so a lot of people still don't even have the clarity as to what they reimburse. I think so far, I don't think there's a lot of problems with reimbursement yet for the people that we prescribe. The companies obviously try very hard. We have mainly, again, stayed towards less sick people, ironically, in this case, as the data has suggested, which is, from a transplant center, is actually not, is almost counterintuitive, because, so that's where the challenge is. And I think at some point you have to have a weak heart. The heart had to be, less than 35%, okay? So I would suggest that at least many of the medical therapy need to be maximized. The biggest challenge is new onset. There's actually absolutely no data for a new onset, because I didn't mention about 20 to 30% of the people actually have what we call heart failure recovered ejection fraction. In fact, my patient population are either the one that dropping off the cliff or people recovered, and many of them are 40, 45, 50, 20% of them are actually 50 or 55. So the exact amount is almost like how we think about CRT. CRT, but not necessarily the symptomatic ones, but the less symptomatic ones. And there's more and more data from biomarkers that would show us that. And to the company's credit, they are going to do more studies on the sicker patients to actually understand, because the vasodilator part is a very big challenge.
It seemed to me your talk was very interesting in terms of when you talked about BNP, because at least the initial trend was don't do BNP-guided therapy. That was 5 years ago, that's what everybody was saying. And obviously now you've stipulated data that says BNP monitoring is useful, and you do it and you believe in it, and there's Are there people who you do believe in it or don't believe in it?
It is
for?
funny because my first paper was on how a quarter of the people with BNP as low BNP are symptomatic, and I got eggs on my face for like the next 5 years because people think that I don't like BNP and don't advocate. We actually did 2 guidelines on this. Just like any other test, the refinement comes from clinical practice. And I think the challenges that we face is that for the people that we actually overlook, we had a lot more devastating consequence if we actually don't understand the risk stratification. So what I talked about is risk stratification. I would be honest by saying that there is equipoise in the field. Some people still feel quite strongly that you do not routine measuring BNP, and I don't routinely measure it if somebody is very stable, okay? But I do order more BNP than echo. There's way more money spent on echo that actually it should. If you look at all echo studies are observational data. Now, if somebody is symptomatically changed, then obviously you do have to explore the underlying mechanism. This is like the smoke in the house. We want to make sure that there's no fire going on. And so I think in the long term, I think we would see a little bit more of that, particularly if there are studies going to directly address this question, which I think will be probably game-changing because now it will not be an imaging-centric disease. It will probably be pushed a lot earlier, and that's what we needed.
Dr. Tang, I'm general surgeon by profession, so I would not understand too much about the cardiological problems. But the problem we are facing is the blood flow problem. And most the emphasis I've heard today is on vasodilatation. But when we hear advertisement by drug companies that it raises your HDL, now where are they going? In what direction? Are they talking about high density flow and Reynolds numbers? Would you comment on that? Thank you.
Well, I can't hear the end. What do you say again? What is? Oh, the rent. Oh, okay. Again, you know, a lot of these description is academically driven. People look at data, they look at population, they look at risks. And it's not just medicine that we face. I mean, we have a security problem now. We need to target the ones that are going to hurt us, and we can't. There's a balance. So in some ways, the balancing is really coming down to what we understand of the underlying disease. HDL and all that, we actually still have a lot to learn. We actually don't have any medicine to lower it. The Reynolds score and all that, and the 10-year risk, all those things, those have been, at least, it's the endpoint that is interesting, because I think most of the Framingham data and all that has been also with mortality. Some of them are with cardiovascular risk. But I think, in summary, there has been a lot of data on getting people who are high risk, and those are people that are stacked upon who actually are closer to having disease. So the time is actually not part of it. So there's a lot of argument with the LDL data and all that, for example, that you actually missed out the ones who are early, who are high LDL, that actually needs the help. So I think we need the tools that are more akin to what our patients have. And actually, that's our job. It's actually not somebody have a computer as a job. We need to actually educate them too. So it is our duty to understand that. And to be honest with you, yeah, I mean, a lot of these patients, there's a previous discussion about chemo, oncocardiology. I don't see a lot of them actually acutely having, cancer, adriamycin-induced cardiomyopathy. Most of them are people who are young, 10 years, 20 years ago when they come to me. The whole problem is actually what happened way early. Okay, so this is the same problem. We cannot actually solve the problem when it's too late. We have to actually go and try to understand how to do it. So then many of these drugs ultimately, when the price get lower, probably will be very, very helpful. Corec is a good example when we have to beg people to take it early on, and now actually we use it like water, and it's actually quite impressive. For the perioperatively, there's a lot of people who have many cardiovascular risk, and that's actually a challenge for us. The vasodilator part, I think, is more of a congested, sympathetically driven situation. So it's a little different from a chronic setting. So both the setting and the time of what it is actually variable, and that's where the physician comes into play.
Yeah, Dr. Tang, realizing that we all physicians are taught to treat the patients and improve their quality of life.
Yeah.
But could you help us to determine the timing when you initiate the discussion about palliative and end-of-life of care for class 4 patients?
Yeah.
And do you start after considering LVAD or left ventricular assist device or before or whatever?
No, actually, in fact, even when they started, and that makes you do very well when the patient actually get better and they thought, oh, you did great. And it's like, in some ways, it's natural history. I actually start them at the very beginning. In fact, even for advanced therapies, our VAD program has a mandatory palliative care consult. They actually have to talk to them and understand all the options and all the natural history. People need to understand what we're dealing with and actually be engaged. So many times, in many ways, if you actually ask patients with cancer, the oncocardiology program is a good example of how commitment of patients make a huge difference. The cancer patients are very committed because they knew the severity of the disease. So is heart failure. We actually have not done a good job in that. Patients still feel that, oh, my doctor can solve this problem. A lot of post-MI patients don't really realize that they have heart failure. They knew that they have a pacemaker and defibrillator. When their rhythm is wrong, they don't know that they have heart failure. It was a shock to them 10 years with a low EF. And it is our failure to do that. So I would say that for palliative care, if you actually frame of it as you need to anticipate the natural history of what's going to happen. And guess what? The goal of care, and I was very simple in saying that, even for transplant eval, I would say the goal is very simple. I want to see you well next year, next visit, next decade, we're lucky, and keep going. I mean, and at every point in time, there are adjustments that we need to make. But it's a fork of the road, and people need to understand they have the choices, and they need to know the choices ahead. So for the palliative care end-of-life discussion, actually comes quite early. Even for patients before they have defibrillators on that, we started talking about, okay, if you get really sick, the thing keeps firing. So these are the things that we spend time talking to our patients.
Thank you, Dr. Tang. Okay. I really appreciate for your excellent lecture. Okay.